Greetings, everyone, and welcome to ACA's first ever town hall virtually. We are very excited to have you all be a part of our opportunity to talk with our members and to really have an opportunity to see you all and hear you all outside of the conference experience. It came to my mind that it was really important for us to be able to talk to those of us who are out in the communities doing the work every day, to touch base and to really just check in. It's been a very trying 2 years for the American Counseling Association because we had not been able to communicate and be together and hang out and do the things that are necessary to kind of just commune and network and be together. And so we really enjoyed this opportunity to kind of be with you all. And I hope that you take the time over the next 2 hours to really engage and network and be a part of this great counseling community, especially this great ACA community that we have. So it's really important that we see you all, we hear from you all, and we get a chance to just talk with you all. Many of you all have not been able to really engage with ACA leadership, ACA staff, in the ways that you may have done so in the past. And so we want to make sure that we avail ourselves to you. Now, the purpose behind the town hall, to give you an opportunity to hear from some experts, which we have 2 today, who are going to be here talking about suicide prevention and things that come along with understanding how to work with clients, how to see individuals when they're working and needing the support of counselors, especially when it comes to people who may be in harm's way. We also want to have an opportunity to talk with Richard Yep, our CEO, to be able to answer any questions you all may have with regards to what is happening with ACA and what ACA is looking to be doing in the future, and what's pretty much happening right now, whether it's something to do with legislation, whether it has to do with the interstate compact. Anything that comes to mind, we want to be available to you all to be able to talk about. And so thank you all for being here today. I'm going to turn it over really quickly to Richard Yep for hello, and then we'll get started with our guests.
Thank you, Dr. Butler. I appreciate that. And I don't want to hog up any time, but I do want to welcome everyone to this virtual town hall. This was an idea that Dr. Butler had that I thought was amazing. The fact that we can all come together regardless of where we might be in the world is very important, especially at this time in society. So I just look forward to hearing from all of you. And I know that the speakers that we have today are going to do an outstanding job. So again, welcome to all of you.
Thank you, Rich. Thank you. And on behalf of ACA, I would like to invite in Rita and John Summers Flanagan. They're going to be able to share with us today some of their expertise. And I'm loving this. Had an opportunity to chat yesterday to kind of get ourselves set for today. But just very quickly, Rita and John, can you introduce yourselves to our counseling community?
Okay. Well, hi. This is a great idea. And I hope it's the first of many successful gatherings. I wish we could be together in real time and space, but this is a pretty good substitute. And I have really missed connecting with ACA people and conferences. So yeah, we're coming to you live from Missoula, Montana in John's office. We have a few tech challenges once in a while, so we decided to minimize the risk and have us both here interrupting each other. I retired about 6 years ago from teaching, although I've stayed very involved in writing and research and trying to keep John on track, which is one of my bigger jobs. And I go way back with the counseling profession and have lots of fond feelings for all of you practitioners and staff. Good work.
So John, that's a true spouse move right there that just got sent your way. Tell us a little bit about you.
It is a true spouse move, and it's a necessary one because I do need some management, and sometimes I don't do self-management super well. So
And the true
you
spouse
know,
response.
we're a team. So I'm John Summers Flanagan, and I want to just echo what both Rich and Rita have said. And so Dr. and President Butler, what a great idea for community. And it feels like we can be an online community together, and the accessibility that you're offering with this event is fantastic.
Phenomenal. Thank you.
So I've been a member of ACA, I think, since 1992, so for a little while. And I have to say some of my best memories of ACA are at conferences. I have, as people probably know, Rita and I have written a number of books together, clinical interviewing probably being kind of the biggest one, but then also Tough Kids, Cool Counseling with the American Counseling Association, our counseling theories text, and then we have a new book out on a strengths-based approach to suicide assessment and treatment with ACA as well. We love to do conferences, we love to do workshops and presentations, and we're honored to be here with you.
Excellent, excellent, excellent. So I want to start off because one of the things that really brought me to you two was the article that you put into Counseling Today with regards to this month and our look at suicide. And those things that come up for counselors, those things that come up for our clients, our students, practitioners all over. And so I was wondering, can you guys give a quick synopsis of that article and what you want to share with the counseling community?
Can I go first this time? So one of the things that I feel that has come through in our training of counseling students is that when the word suicide is mentioned, there's lots and lots of anxiety and concern about what's going to happen. Am I going to say the wrong thing? And can I really predict the risk of suicide? And one of our goals with the book and with the article in Counseling Today is to really give the message that suicidal thoughts are a normal human response to a very difficult situations, and they can be psychological situations or they can be cultural or environmental situations. And so we want to make that more normal. And we also really want to give the message to all practitioners that when clients say they're suicidal, that's a really good thing. That's why we're in this whole profession, is because when people say they're suicidal, we get a chance to be helpful. If they don't tell us that they're suicidal and they're feeling that way inside, then we lose the opportunity to help and to connect with people on deep levels.
The other thing I think we want to add or encourage people to do is when faced with the need to evaluate someone's suicidality and decide what to do, it's easy to panic and go fairly negative and ask lots of hard questions that are depressing to answer. So we have a strengths-based approach that we really, really believe in and preach firmly that you should not assess in a way that leaves someone feeling worse than when you started. So It's your job to find those strengths and emphasize those as well.
Can you talk a little bit about how do we get out of our own way when those types of things happen? How do we come to self and recognize that we need to center ourselves so we can be there for those individuals?
That's a great question. You want to?
Yeah, I think getting centered before our sessions, knowing that suicidality is a possibility, and then greeting the suicidal ideation or the suicidal impulses that come out, greeting those things with acceptance. And really part of the way, what I think happens for me to get out of my own way is I need to recognize that when someone discloses suicidality, it's really a gift of connection. It's a gift of depth. And that if I can understand and accept what people are experiencing, then I have a much better chance to be of help.
Wonderful, wonderful. So what got you started looking at this particular avenue of counseling?
Well, for me, on my internship, we had a number of guest speakers, and One was a practitioner who had had a adolescent who he'd seen and finished working with, and later the young man died of suicide, and the family sued the practitioner, and it was a nightmare story. And I still remember this clearly, sitting in that room thinking, I will never see an adolescent who looks even a little bit sad. It was just so scary. And then we got into the real world of practicing. And like John said, people struggling at that level are sometimes the most engaging, amazing people ever. And I decided the risk was worth it.
Yes.
And that's another way I would say you get out of your way, is just accept that there are risks. You cannot keep someone alive. It's not in the contract. And sometimes you will be accused of, malpractice. It happens. Just accept it. You'll see your way through it. And that lets you stay vital in the room.
So counselor educators especially teach students to kind of give a contract between sessions to clients. Can you talk a little bit about that? What's your thoughts on those?
Yeah. I mean, the whole idea of Rita and I have been doing presentations on suicide assessment and treatment for a long time. And in the 1990s, when we were doing that, we had an overhead, right? Back in the day of the overheads, put the overhead on, and it said, do a contract with your adolescent client that says, I promise not to kill myself on purpose or by accident, right? And so it was worded in a way that kind of appealed to teenagers. Well, as it turns out, in the late 1990s, that really went out of fashion. It went out of practice. We're not supposed to do, quote, no suicide contracts anymore. Instead, really, it becomes, and it's partly related to the clients and the patients were having reactions of, well, if I sign this, I'm just really protecting the provider. It's kind of like the provider is using it as cover for liability. And of course, it wasn't a very good cover anyway. So clients didn't like it, patients didn't like it. And then as it turns out, that's asking people to not do something negative. And so now we do collaborative safety planning. And there's a great article by Barbara Stanley and Greg Brown that kind of outlines it. You can find the safety planning intervention online. It's free. There are like 6 or 7 steps to it, but it's an agreement that's really more interpersonal about, let's make a plan about positive things you can do if you're in a suicidal crisis.
Yes.
And that's a nice tweak, right? It's to do something positive for yourself when you're feeling you're in a suicidal crisis, instead of saying, I promise not to do the negative thing. Right, so it's a much better way, I think, to approach it.
Thank you. I appreciate that. You talked about adolescence and making sure that nobody goes through that again when you were in their presence, Rita. Can you talk a little bit about what school counselors and counselors in general, but especially school counselors? I'm a former school counselor. So what should we be doing to make sure that we are being on the outlook or the lookout for students who might seriously need our support?
Well, do you want me to? So one thing we are recently very excited about is introducing the ideas that come from positive psychology. And so instead of assessing your students or monitoring them in the hallway for seeing yourself as watching for depression or watching for agitation or watching for impulse control trouble, I'm framing that now as seeing them as the kids who need help developing their potential to be happy, their potential to live well-lived lives. That's where we swoop in and say, hey, it doesn't look like you're living up to everything you might want to be, or things aren't going the way. So that's my newest spin, is that even suicide assessment should be seen as the assessment for the potential to become happier.
Beautiful, beautiful.
Rita's really on the cutting edge. I mean, and we know in the US that school counselors are just really saddled with such huge burdens around suicidality. One of the truths about suicidal adolescents, but adults too, is that even though there are risk factors and warning signs, the empirical research would suggest they're not very robust in that many suicides and suicide attempts are pretty unpredictable, right?
Mm-hmm.
And then there's that old principle of whatever you pay attention to grows. And so I get worried with that kind of universal screening mentality of screening for depression and suicide. Not that we should maybe completely stop doing that, but I do like Rita's cutting edge approach of let's do screening for wellness, let's do screening for happiness, and then you will undoubtedly, it'll be a more appealing process. And then if you find some children or some students who are struggling, then we develop a coaching or a consultation or a counseling model to help them move toward greater happiness, greater fulfillment, greater meaning, whatever words we want to use. And we will find some that are super depressed. And then we can use our more traditional means of dealing with them. And so I think that's a really interesting way of reframing how we even look for suicidality. Of course, we look for it, but also we should be balancing that with a search for happiness amongst the students.
Can you talk a little bit about self-care? What should counselors be doing, especially in these times when they may be dealing with someone who is suicidal and, you know, they need to be able to center themselves, calm themselves, be there in that moment for those individuals. But what about self-care?
Yeah, you know, I probably would just I start by quoting maybe Alfred Adler or the whole idea of having a community, to not isolate, to say other people matter and I matter to other people, that we are in this together. It's a lot like why we're having a town hall. We should not be in the business of suicide assessment and treatment all by ourselves.
Nice.
We want to support each other. I just recently had an article published in Psychotherapy Networker about a teenager I worked with who died by suicide. And I think it was so hard to get through, but with Rita supporting me, and I had a supervision consultation group of peers who supported me, those were just so essential. And so for self-care, we can do a lot of things ourselves for ourselves, but we also need to have our community. We need to have our connections. We need to have support from other professionals.
Yeah. What would be your message to students who are studying right now, who are getting ready to get into counseling? How do we get them to be Rita and John Summers Flanagan in the future?
Well, I would recommend that they become the best versions of themselves. And if we can have a little bit of role modeling and mentoring on them or with them, that's great. But, you know, and I'll speak for myself, and Rita, you may have different feelings, but for me, the whole concept of counseling and helping others has just been a passion. And so some people ask, like, well, you know, what do you like to do? And I think, well, I like to do what I'm doing professionally a lot, because it gives me a chance to do something that's meaningful, that might have a positive impact on other people. And so I think to really follow that passion of trying to care for and be present and be skilled in our work to help other people. For me, that's just like the attitude really helps. That's my goal. And hopefully I can try to get there.
Right. So we kind of talk a little bit about what counselors should do to work with their clients. But Rita, you brought up something a little while ago about someone saying or being sued, or there being a lawsuit that might come with your service to a person. Can you talk about what a counselor could do or should do in that case when they have somebody who comes at them and says that they're responsible for a person who tried or may have followed through on a suicide attempt?
Yeah, I think that you have to go back it up a little ways and hope that, like John said, you're in a consultation group. And I like to lean in and give, you know, the evil eye to everybody and say, you're not the lone ranger. That's dangerous. You need colleagues you're hanging out with who will tell you when you need help, when you're off track a little. That's just super important.
So let me just stop you for a quick second and just tell you, when you leaned in just now, I felt every bit of that. So anybody who talks about telemental health not necessarily working, that's not true. Because when you leaned in, I said, I almost went back. So I hear you, but I'm sorry, I cut you off. Go ahead.
No, that's great. I'm glad it was effective. I'll try it again in a little while. So the other things are, of course, stay up on the literature. You should be, I think a lot of states are moving toward continuing ed requirements for suicide assessment and intervention. Documentation is huge. It doesn't hurt to have a friend who's an attorney. I guess those are the main ones. Do you have some?
Yeah, just a couple of things to add. I just did an online training with David Jobs and with a representative from an insurance company about liability in suicide and suicidality. And they both said the number one thing is to be human. You know, somebody approaches you, don't be defensive, don't hide behind your degree, don't hide behind your professionalism, but to be human. And they're in a tough place usually. And so using our good counseling skills and our humanity, kind of step one. And the other thing they said that really struck me was, they said, you know, that the instruments or the screening instruments really not that useful unless you get sued, which is kind of funny, right? But so David Jobs recommended using the the ASQ, which is available online. It's a suicide risk screening tool, and so it's a four item thing. You know, online they say it takes 20 seconds to administer. I think that's a little quick. We as counselors like to do things that take a little longer than 20 seconds. But to use some state-of-the-art assessment, even if it means a short 4-question instrument that you're checking with people, have that be part of your practice. Be human if people approach you and attack you. Be compassionate for them and with them.
Also, one quick thing, I'm a big fan of informed consent, both verbal informed consent and written documentation. And I think sometimes certain contexts, we're so busy, we have people fill out paperwork and then we get in a meeting with them and we forget to look thoroughly at what they filled out.
Right.
Very bad mistake. Yeah.
Definitely that. So listen, we're getting close to the time when I want to open it up to our viewing public and those who are in the Zoom room with us. And I wonder if you have any last minute things that you want to share before we get to taking questions from our audience.
Well, I just want to say thank you both for this opportunity, but also I really want to just speak to you who are listening in the future. Thank you for doing this hard work. Suicide rates are climbing. There are many, many reasons for that. And we have a lot of important work to do. And thank you for being out there doing it.
Excellent. Thank you. John?
Yeah, one last thing. You know, in the suicide book, we talk about the 7 dimensions to assess. And because when we're working with people, a lot of times our anxiety will make us get tunnel vision and just sort of suicide. We've got this 7-dimension model, includes spirituality, includes culture, includes the context in which people are living, and includes behavioral, and it includes cognitive, and it includes emotional. So to remember that there's all those different dimensions with the individual, and to try to not over focus or to engage in cognitive restriction or constriction, and to see that whole person in front of you, because they have strengths and they have resources, and we need to be in touch with that as well.
Thank you. Rita and John, I can't thank you enough for being a part of today, not just right now, but you're going to be in a breakout room later to talk more with people on a more individualized basis. But the work that you all have been doing, you know, you are a godsend to our profession, and I really appreciate you. I appreciate you taking the time out for us today. And just the good work that you've been putting out there. I think it's supported and helped a lot of people along the way, especially us counselors who may be kind of sitting back and not necessarily sure what we should do. You provided a platform and an ability for us to move forward in a way that will be really supportive of our clients. And so just thank you so much for all the work that you've done. I want to open the floor up to all of our participants today. And I would ask that we raise our hand and get into the queue, so to speak, so that we can call on you to ask any questions that you might have for Rita and John, Rich, or myself. We want to open it up and really be there for you all. And we hope that you'll take this opportunity to do this and really hear from you and hear your voices. I will say that we want you all to be respectful, and we want this to be a time for us to be able to really show up in our best counselor selves and really have an opportunity to kind of communicate with where we need to go. I see Mario Burns in the chat and with his hand raised. So Mario, the floor is yours.
Good morning and good afternoon, depending on where you are in the country. Everyone, it is such a pleasure and an honor to be here. Dr. Butler, sir, congratulations on being the 70th president of ACA. Sir, I'm so incredibly proud of you. It is great to see you again. Everyone, Dr. Butler was a professor at the University of Missouri, St. Louis, and I attended as a student. And Dr. Butler actually taught my first multicultural counseling course that I received. In fact, I skipped a semester when I had an opportunity to take the course because I heard about how well he taught the course, and I wanted to ensure I had the course with him. And so, Dr. Butler, to see you at this point in your professional career, it speaks volumes, and I'm so incredibly proud of you. And I thank you for this opportunity.
Is there a question in there? Is there a question in there?
Yeah, I say all this to say, everybody, right now I work with the Vet Center in Nashville, Tennessee. I work with veterans that experience military trauma, post-traumatic stress, things of that nature, family, marital issues. One of the most salient things that comes across with all of my clients, their families, something that we're facing in the nation as well, is this challenge that we're dealing with the concept of race. And I wanted to pose this question to you in particular, Dr. Butler, because of your expertise in this area. I recently had a published manuscript with the Professional Psychology Research and Practice, and the title of the manuscript is Race Meta Theory Toward a Dissolution of a Calamitous Concept. Race is not a biological reality, but rather a peculiar social construct that's used to divide people. Earlier this year, I wrote a letter to you as well, Mr. Yep, and it's a pleasure to meet you. And I sent a copy of the manuscript prior to its publication, but essentially what race meta theory calls for is a dissolution of the concept of race within the United States of America.
Okay.
The concept of race is indeed an invention that was contrived at one point prior to us being born, or anyone else that's alive being born, but it was devised to divide people. And we still currently have these terminologies to describe and group human beings into homogeneous groups of people. Right. And essentially, what race meta theory points out is that by doing so, we do so in error academically because people are not monolithic groups. And so to group people by their skin color and to categorize people into these so-called racial groups is highly inappropriate, and it does not serve science, the advancement of science. It's non-scientific, in fact. And so my question to you is that with this information, because this is some information that you've written about extensively, some information that you've taught in regard to the social construction of race and how it was created in this nation. My question is what are we doing within ACA to discontinue to propagate the propagation of race and this idea, this concept of race, which is a stain on our country? It continues to burden our country. And what are we doing to address the issue? Because by virtue of continually discussing it in the manner in which it currently is contributing to the incalculable problems that this concept presents. And so my question is how come we are not moving towards a dissolution of race?
Well, thank you. Thank you for that question. Thank you for that background. And I will share with you all, that's why you need to take one of my courses, because you can ask questions like this of those who are able to answer them, hopefully. Well, first, let me just tell you that one of my strong points for this year is inclusion, and inclusion through intersectionality. And so I too, like you, understand that the concept of race categorizes and puts people at a disadvantage. And so how do we work around that, right? How do we allow ourselves the ability to kind of see people for people and work from that regards? I think counselors can help in that regards, but I also know that it's the social justice advocates, it's the individuals who are out there helping to change the narrative and the conversation around what that looks like. You're talking about years and years and years of people being kind of ingrained with this mentality. And how do we change that? How do we help to move that? My philosophy is that we do it one person at a time. We just continue to do that. I think that ACA stands behind trying to make sure that each person is seen for their own individual self, and that they are regarded in that regards. They bring to the table who they are, and then they are respected upon based on what they do and how they share themselves. I think that's what we can do. But like you, we continue to have conferences, we continue to have programs, we continue to have platforms where people can start to talk about these things in a much more engaged and much more productive manner, right? I am really big on difficult dialogues, and I think it's really important for us to be able to look at that. So Mario, thank you for that. Come into the, I want to give others some time, so come into the breakout session with me in the next hour, and we can continue to dialogue about some of these things. But I see other hands up, so I want to give other people time.
Thank you.
And this within this hour. So thank you, Mario. Is it Brandon?
You got it. Good job. My name is Brandon Rourke-Kairis. And thank you, Mario. I thank you for that manuscript too, and sending that along. I think that that's really important, and a really important piece of this conversation. And Rita and John, I just had a question for you. I'm your neighbor over in Bozeman, Montana. And in our state in Montana, we have the highest rate of suicide. And so thank you so much for your work. It's so important. And I'm excited to check out your book. My question is about the screening tool that you discussed. And this is, John, as you mentioned, like this is the shift, because I see a lot of screenings in schools in regards to, not strengths-based in that sense. But I'm wondering, in your book, is that screening tool included in that book? And then in addition to that, developmentally, what age spectrum is it most appropriate for? And the reason I ask, I do ACEs screenings and ACEs trainings with the preschool, with daycare centers, caretakers, preschool age, and early intervention. We always talk about that piece. And so can this tool be utilized as well for those earlier years for our kids? Thanks.
Yeah, Brandon, that is a great question. One of the things that I said when Rita mentioned the approach of looking at happiness potential is that she was on the cutting edge, meaning that it's not in the book. And it's really more of a concept right now that we're working on making into a screening process, and so I wish it was. I wish we were already there. I do think that there's a lot to learn from ACEs screenings. There's lots to learn from the traditional SOS screening that I know is done in a lot of Montana schools, certainly from doing the ASK or ASQ screener. So we learn a lot, but again, we learn a lot about the negative side of things. And so really what we've been talking about is not really an official tool or screener yet, Brandon. We wish it was, and maybe you can help us do the research we need and the practice to start to move in that direction in the Montana schools as well as other schools.
I also think it's an attitude, and you can use the worst instrument in the world and do it with finesse and grace and compassion. And you can use the best instrument in the world and make someone feel terrible. It's a clinical interaction, and you need to loosen up around these assessment questions and make fun of them sometimes and come alongside and normalize and be human in the process.
One of the frames I try to give everybody around screening is when you have to do a screener, and it's just something that your employer has you do, or you want to use it, either way, to say to your client or the student or the patient, I'm going to ask some questions off this questionnaire, but I want you to know, I want to know much more about you than just these questions. This is just one small way that I can get to know what's going on with you. So like in the ask, the first question is, in the past few weeks, have you wished you were dead? That's a passive suicide question. In my mind, it's not a super great question, but it's part of the screener. I would want to make sure that I also asked the other side of that question. In the past few weeks, have you been glad you're alive? And when did that happen? And so I would try to complement some of the negative questions in a traditional screener with other questions that balance the process toward the positive.
Thank you, Brendan, for that question. Next, we have Leslie de Blasio. I'm sorry, I caught you doing something, Leslie. I don't know what I caught you doing, but.
Taking notes.
Right.
Thank you. Good afternoon, everyone. I'm Leslie de Blasio. I'm a licensed professional counselor and licensed clinical alcohol and drug counselor in New Jersey. This town hall is extremely timely. I'm currently dealing with a teenager who I've just recently started meeting with, who last night dropped a bombshell on me. She had written a 10-page plan. She called it a dumb plan, but it was a plan nonetheless. Not terribly imminent, but she referenced thinking, maybe she would do it in next April after her science fair is done. And it kind of helps her. She told me to get through the day knowing that she could do this, in the future. Did not want me to tell her mom. She's 17. So I'm looking for some tips. I actually did speak with her mom today after a very poor night's sleep last night. I did speak with her mom, who was calling for a psychiatric referral, because I did ask her to talk to her mom about referral to a psychiatrist. So just looking for tips with regards to confidentiality. Obviously, our rapport is probably very compromised today. After today, I did ask her mom to talk with her and see if we could all meet together. So just looking for some direction. I appreciate it, and thank you so much for your work.
Yeah, thank you so much for sharing that. It's a great example of how hard it is to do this work and what precarious positions we get in. And I can just hear in your voice the exhaustion. And so thanks for sharing that. That's so hard. Just a couple of thoughts, and it's obviously the kind of thing that deserves much more time. I'll have Rita deal with the confidentiality part if you want, but just one of the things that the 10-page plan, the 10-page plan to me is also a 10-page opportunity. There's a question David Jobs uses in his approach called the collaborative assessment and management of suicide. And the question is, what one thing, if it changed, would make it so that you would want to live? And so my guess is that this 17-year-old has thought about the many things that make her want to die, and that she wants to, and suicide is a method of alleviating that pain and that disturbance and that distress. But I'd also be interested in her and collaboratively trying to get her to develop a 10-page plan for living to help, just because everybody needs a balance. Everybody needs to balance things. And I would ask that David Job's question to help move her toward what thing do we or could we work on to get rid of in your life so that you would be more likely to embrace it. So that's a quick kind of therapeutic response that comes into my mind, recognizing that you probably have a relationship rupture. I love the idea of you meeting together with the mom and the daughter, because right now that's what you need to have people on her team and to realign with her and repair the rupture.
Confidentiality with humans from age 14 to 21 is really tough. So you need to know your state laws. You need to know the content that allows a break and the content that does not. And like I said earlier, I'm a huge fan of informed consent. And I think most of us manage to tell our clients in some way that if we believe they're in imminent danger of hurting themselves, killing themselves, or killing someone else, we will break confidentiality. So that's very important to have out front. You never know when that bomb will fall, and when you break, no matter how well you've prepared, it's a rupture, and one that you have to see if it's repairable, or at least take responsibility for your side of it and explain that your actions came from love and concern. But I would also consult every state and every college campus and every agency has sets of rules, guidelines, and laws that guide when you can disclose information. And you want to make sure you understand. I don't know New Jersey's laws, but she's in a gray area in terms of protecting her right to have that information stay confidential.
Rita, thank you for that. And one of the things that just came up for me in some of the words, the word choices that you and John just used, the word rupture really struck me. And I'm wondering, can you talk a little bit about word choice and what we can make sure we're doing in the presence of those who are hurting to make sure that we don't take advantage of their pain and hurt them further? And I'm just wondering if there's something that might be supportive of how to really engage with someone, because I don't know what it was, but something about that word just struck me just now. And I just wondered, when we're working with someone who's vulnerable, what types of words might not be the best ones to utilize?
Yeah, just in this context, of course, rupture is a powerful word and it conveys a lot. And one of the reasons I think that I found myself using it in this context, probably would not use it with a client or a student, because it's one of those technical kind of counseling and psychotherapy relationship words. The reason I used it is mostly because we all know that with teenagers in particular, they will ask you not to disclose. They'll ask you not to break confidentiality. I know we've had cases, students who ask us not to, and yet our professional obligation is to keep the person safe. And so we make the choice to disclose anyway. And so that is a break in the relationship, that it hurts the trust, right? Because even though the teenager was very clear, don't tell my mom, please don't tell my mom, you need to tell the mom. And so in order to keep the child safe. And so that's the nature of the relationship, and it's a relationship rupture. It's talked about a lot in the psychoanalytic model, where then we take steps to try to repair the rupture.
Mm-hmm.
I think that rupture is a much better word for us to use as academics than for clinicians. And I think my sense of what you were saying is that, are there some words we should avoid?
Well, I think about it in terms of our first goal is to do no harm, right? And it wasn't that I took it out of context. It was just that word was just striking to me. And we're talking about a very serious subject here. and you know, what might we tip the scale on in some regards when we're working with our clients, you know, when we teeter between what we do in our professional and what we do when we're working with our clients, right?
Right, right. I teach our counseling students a lot about how to handle termination. And then I saw a video, and my counselor supervisee is using the word termination with the client. And I'm like, no, never use the word termination with your client. You use the word end, say we're ending counseling, right? We just use that when we're talking in our academic setting about ending counseling. And so it's a funny thing, right? I mean, and it's hard to know.
Most people don't know that the textbook is actually just a blueprint to doing the work, right? It's never really telling you what words to use. It's telling you how you can go about the counseling process.
Right. Yeah. So I wouldn't use the word rupture. I wouldn't use the word termination. But then the other issue that I think is really interesting is we never know in advance what particular words might offend or bother or cause some little relationship break with a particular individual client. And sometimes the intercultural communication makes that even more risky, right? We don't know. We might use a word that would be offensive to someone who is different from us in terms of cultural background, right? Or ethnicity. And so I think one of the things we try to do, and it maybe happens early in counseling, like Rita's informed consent process, but we might want to say, there'll probably be times when I might use a word in here that you don't understand or that really bugs you. And that I hope that you can tell me that, because my goal would never be to bother you with the language that I use. My goal is to try to communicate as well as I can with you. And together is the best way we can make sure that we're communicating clearly. And if I ever say anything that bothers you or that offends you, I really hope that you will let me know, because that's absolutely not my goal.
Yeah. Thank you for that. And and for our guests here today coming in and asking questions, I shouldn't really call you guests. You are members of ACA. You are here. You're one among us. We got to be very mindful of the fact that we're asking questions and we're making sure that we're keeping our confidence of our clients as we move forward in this. And so how would you say, Rita and John, that we engage in conversations like that, especially around our clients when they're so serious in a town hall type of a platform, to ensure that we don't break confidentiality?
I feel like I've been talking a lot, Rita, so
Sure.
it's a hard question.
Yeah.
So I think maybe you
Pass
should
those
answer.
hard questions over to me.
That's what our spouses do.
That's right.
So if I have the question sort of understood, you are asking, how do we gather professionally and talk about really tough clinical situations and quandaries we face, and do that in a way that doesn't violate confidentiality and or cause harm in some other way that we wouldn't want. So it's similar. We're kind of our own big giant consultation group right now. We're talking about clinical work, and there's no absolute perfect answer to a lot of things people could bring up. I think that when we talk about clinical work and have questions, we definitely do not want to identify a client in a way that someone else down the road would say, oh, I know who that is. That's not okay. You can disguise the sort of less important parts of your work or the client so that it's blurred and not, but still acute enough that you get the input you hope for. The other thing I would add is there's no easy answer. There's no one answer. It varies so much by context and the relationship and the rules and regulations and ethics as they shift over time. So again, hanging out together and doing lots of reading are good solutions to that. Did I get at what you were asking?
Yes, you most definitely did, and I appreciate that. And I think our viewing public here gets it and understands it as well. So I thank you for that. I want to throw a question at Richard Yep. While we're waiting for others in our audience to ask questions, Rich, could you possibly give us a little bit of an update on what's happening in ACA? What are some things that our members should know, especially those who are hanging out with us today? What might be some things that they would necessarily need to have a great understanding of where we are today in ACA?
Sure, I'd be happy to do that. There's a lot going on at ACA, and a lot of it is driven by what a number of you and your colleagues who are members have indicated that they want. What we are about is not just asking you for your membership money. We want you to be engaged, and we know that you're going to be engaged if you see that what we're producing are things that help you. So, for example, John and Rita's book, it's a great book. There are a bunch of great books that we're working on, and I hope you take advantage of that. The other thing is, a lot of people have talked about, well, what happens if I'd like to practice somewhere other than the state in which I'm in? How can I move to another state without having to go through all the hoops of being licensed again in that state? And so Kent and the rest of the governing council allocated a significant amount of money to us to go ahead and move forward with the counseling compact, which Dr. Lynn Lindy, who is the head of our knowledge and learning unit, is overseeing. And what the counseling compact would allow is to give you that privilege to practice in another state for those states that are part of this compact. And we've made great progress on it, and we're going to continue to make great progress, I think, over the coming year. So those are things, that's just like a little example of what we're doing to help advance the profession. The other is when COVID hit, and as many of you know, you had to start doing telemental health. So ACA did provide, the several courses on how to practice using telemental health. We made that available to not only to members, but to non-members. And we did it at no cost because we felt it was a public service to the profession. And I was really impressed that more than 32,000 of you signed up for those courses. These are just things that we don't always want to just react to something, but we want to be ahead of that curve. And to do that means we need to hear from you. We need to hear what's going on in your mind and, in your practice or with your students. And the more we hear, the more we can try to develop things that hopefully will be of benefit to you.
Thank you, Rich. I appreciate that. I want to encourage any questions from the audience. And if you maybe not want to come on camera or Taylor, I don't need to go any further. Hey, Taylor.
Yes, hi everybody. I'm Dr. Taylor Bigelow. I'm an assistant professor at the University of New Haven in Connecticut. And this is just a question I've been mulling over, and I don't know if it's fully formulated, so bear with me. I'm curious about the intersection of crisis assessment, whether it's suicidal ideation or homicidal ideation, and its intersection with policing. And thinking about our protocols, right? When we know if we, call in a crisis situation, there's numerous examples we can point to of folks ending up deceased or dead or murdered as a result of police involvement. And I know this is a emotional discussion perhaps for many of us, but it's something that my students have asked me, right? They're like, what do we do? How do we do no harm and keep clients safe when we do have some doubts of what it might mean to call and utilize law enforcement in a situation such as a crisis?
And I'm going to ask you who you're directing that question towards, but I'm thinking it's Rita and John, but I just want to make sure.
Rita and John. Yeah, happy to clarify. Just wondering if you've run into this or any advice, just knowing, your expertise on the subject matter.
My main hope was it was for Dr. Butler, but so really, really good question. I think it speaks to the importance as for us as mental health professionals, school professionals, to be involved in community, in our local communities with the police force, and to the extent that policing happens, the more of us who are involved in communicating with people who are in the police, the better, right? Because they learn from us, we learn from them, and we want it to be less us and them and more we. and certainly more and more as long as possible before ever reaching out to the police or an emergency service.
I want to add something real quick. It's also the other side of the coin is that we are not God. We can't keep everyone safe all the time, and we cannot and should not cross boundaries that put ourselves at risk. I'm not a big advocate of you putting pictures up of your family members or identifying stuff in your offices. I don't think we're called to break those boundaries to humanize ourselves, but absolutely, definitely do not put an agitated client in your car trying to get them somewhere safe. You are not there to shield someone else from a bullet. And these are tough things, and they're true things. And yes, sometimes you call in emergency help and it's not skilled help and things go terribly wrong, but your job is a different job than that.
Thank you so much for sharing that. We are coming up on 2:57. I see Linda. Linda, you will be our last question for today. Linda, go ahead.
Well, this is maybe more a comment, but Rita, your last comment kind of triggered a thought in my head that we are not God. And one of the things that as a counselor educator, I try to do with my students is to help them understand that if they stay in counseling long enough, sooner or later, they probably will have a client commit suicide, and to anticipate with them some of the feelings that might result from that. One of which often is a lot of guilt that I could have done something different or more. And one of the things I try to discuss is the fact that we are not God, and that we cannot, if we believe that that clients have the power to make their own decisions and the right to make their own decisions, that we can't take responsibility all on ourselves for that action. And that, we don't take responsibility for their successes. Why are we trying to take responsibility for a suicide? And I actually had a student once, years later, contact me and say it had finally happened with her and that she was devastated. And the only thing that got her through it was remembering my voice in her head, kind of challenging her a little bit on taking all of the responsibility and the guilt around that. And so just a comment that, I think that taking an empowerment view toward the act of suicide, I think is helpful in terms of self-care after the fact.
Thank you so much, Linda. I appreciate it. We are coming to the close of our first hour. I want to again extend a phenomenal thank you to Rita and John Summers Flanagan for not only your expertise, but the thoughtful and positive way in which you shared it with our community here. And I want to thank Rich Yep and the staff of ACA who have done leaps and bounds beyond what is necessary to put this together. We hope that you will stay for the next hour. We are going to be breaking into breakout rooms. You'll still have opportunity to ask questions of John and Rita, but you'll also be able to go into various breakout rooms. And in a few minutes, you will see a pop-up window listing our available breakout rooms. If you don't see the pop-up, please check on the bottom menu on the Zoom screen there, and you'll see an icon for breakouts in 4 tiny boxes, and just click on the one that you'd like to choose to go to. Now, the purpose of these breakout rooms is for networking, for asking questions, to get information from each other, because we're all experts. We all understand what's going on. And if you may have questions, whether you're a student, whether you're a practitioner, whether you're a counselor educator, However you show up, bring yourself to those rooms. I also will be in a room just to be there to communicate and talk with individuals about what's happening. But we would love for you to be with us and stay with us. Make sure you turn your cameras on, your mics on during that particular point in time. When you switch into the breakout rooms, if you want to go into another breakout room, be careful when you go to leave the room, because you can either leave the Zoom platform or you can leave the room. When you leave the room, you'll just go right back into the main room and you can be able to make a decision where you want to go from that point forward. So just be mindful that the icons are tricky when you try to do that. We will adjourn directly from the breakout room, so you don't have to come back to this main room. There will be a broadcast of a 2-minute warning that lets you know that get it out, say what you got to say, because in 2 minutes, boom, you'll be cut in half in terms of this, where you are in terms of the message that you might be communicating at that time. There will be only one breakout room that's being recorded. That's the room that Rita and John are going into, so that we can have possibility of sharing this information around suicide and suicidology with our community. And so if at any given time there is any type of technical issue, please communicate with the person you see that says ACA events. And I thank you all for taking the time to be with us and seeing that you are still here. I'm loving that. One last bullet. Please, please, please share that we have the podcast going on. They drop on every Thursday. They're on YouTube, Spotify, Apple, iHeartRadio, all those different things. Share it with your students, share it with individuals to kind of see what's going on in the counseling community. But we really would love your engagement when it comes to the podcast as well. So with that, no further ado, please find yourself moving into one of the breakout rooms. And thank you so much. I am blessed by your presence, and I hope that you have a phenomenal rest of your day. I'll see you, whoever comes into my room.